Thank you very much, Jordan, and thanks a lot for the introduction. And I'm very glad to be speaking to you all today. But please do not ask me about whether you should send your child to school. My answer to that survey was very clear. I don't know. So that I'm glad that's not what we're talking about today. Let me just share my screen. Okay. Okay, so what I will be talking about is related to issues with tracking excess mortality in countries with limited death registration. And by limited countries with limited death registration, I'm mainly focusing on low and middle income countries, primarily in Africa and South Asia. Sorry, just trying to move. Okay. So to begin with, let's review a little bit how a pandemic population level, and in short, it does so through direct and indirect effects that you. I'm sorry, I have issues moving between slides.
Yeah, also, I don't know if you can do anything, Stéphane, but the voice started to go a little bit strangely.
Okay, I might have to stop my video then.
Yeah, well, actually, the voice just got better.
The voice just got better? Okay. Okay, that seems to be working too now. So there are multiple causal pathways through which an infectious disease and a pandemic like COVID-19 might impact population health and mortality. One is through direct effects. That's basically to say that some people will get infected with the virus and will ultimately die from COVID-19 or related condition. But there are also additional deaths that may occur due to disruption caused by epidemics and pandemics. And these are usually classified under all the indirect effects that these pandemics might have. So these result, for example, from reduced healthcare utilization during a pandemic. For example, if health systems get overwhelmed, or if potential patients become wary of attending health facilities. There may also be economic effects of pandemics that might have an impact on people's health. So, for example, in low-income countries, that might have, and in disadvantaged population, that might have something to do with nutrition. There might be mental health consequences. On the other hand, there might also be reduced road traffic and accidents if people are increasingly staying home to avoid the transmission of infectious diseases. And the problem we have, well, so how do we measure these issues as an epidemic or a pandemic unfolds? Well, during an epidemic or pandemic, health information systems traditionally aim to record the direct effects of the infectious disease in real time. So you've become very familiar with this through the daily tallies of COVID cases or COVID-related deaths that are reported in the media, for example. One thing that's important to know is that these numbers that are reported on a daily basis, they usually focus on deaths that occur in hospitals, so in a very specific setting, and they depend on testing for the virus that causes COVID-19. So they're classified as COVID-related deaths if there is a preceding positive test for the virus. Through this system, some deaths might thus be misclassified or attributed to other causes. Early on in the pandemic, for example, there might have been a number of deaths that were classified as attributed to pneumonia or other pulmonary ailments and so on and so forth. So there are important issues here. Importantly also, our knowledge of the indirect effects of a pandemic or an epidemic usually take more time to emerge and is usually more limited, at least as the pandemic is unfolding, due to the timetable of data availability, whereas systems spring in place to report on COVID and COVID-related cases and death. We do not have systems in place that report about all the other causes of death that are out there. So now, since the beginning of the pandemic, there's been an increasing focus on a more robust measures of all these kind of combined direct and indirect effect, and that's what has been called excess mortality. And excess mortality, to put it very simply, that's the number of deaths above the number of deaths that would have occurred if the COVID-19 pandemic had not happened. So here we're talking about a counterfactual measure, and we usually get that counterfactual from the modeling of weekly series of deaths that we obtain from a vital registration system. So we model them in certain ways to account for the seasonality of death, for long-term trends in mortality, changes in population composition, and on deaths from all causes, just COVID-related. So we have we're pursuing something that encompasses both the direct and indirect effects of the pandemic. And in terms of visualization, we try to produce figures of this kind, which I drew from the new data series that's been released by the Human Mortality Database on short-term mortality fluctuation. So as you see on this graph here, you have a number of lines that are counts of deaths per week, and that represent the number of deaths that were seen in a country, here England and Wales, in previous years. So the gray lines here. The red line here is the representation, is the resulting of the modeling that we do, and that's the expected level of mortality that we would have expected to see if the pandemic had not happened. And the black line, on the other hand, represents the count of deaths that were enumerated this year during the pandemic. And the red area represents this excess mortality. So how many more deaths are occurring this year compared to what we would have expected in the absence of the pandemic. So that's what we are trying to calculate, and that's what we are after, to try and gauge the total impact of the pandemic on population health. So that's a very powerful measure. And one that requires relatively simple data to be computed, because it requires data from a complete vital registration system. So data that is the kind of the bread and butter of demographers, and that are available for at least a high-income country. And I'll talk about that shortly. So we need timely registration of those deaths and timely reporting of those deaths, so that the excess can be tracked on a fine time scale, so on a weekly or monthly basis. And if possible, we also need population counts to account for changing population size and composition from year to year, in particular during the course of the pandemic, if it precipitates additional movement, or if it reduces the mobility of people, then there might be some confounding that needs to be accounted for. So the advantages of such a measure is that they are not affected by limited availability of tests for SARS-CoV-2. So because we are counting death from all causes, regardless of whether they can be attributed to COVID-19 or not, it also bypasses issues of classification of causes of death. It includes the indirect effects of the pandemic, which are traditionally more difficult and less timely to assess. And it should be largely comparable across country and over time if the vital registration system from which the data come are complete and resilient or robust in the face of the pandemic. Now, the main issue we have, if besides data availability, and I'll get back to this, are delays in reporting. So if it usually takes longer to compile this data than data about hospital deaths, and there are usually delays that vary between jurisdictions. So, for example, within Europe, between countries, in the US, between states. So if we want to compare these measures, it might require adjustments for timeliness. Now, that's for the rosy ideal picture of data availability in a lot of the countries where COVID spread first, so high-income countries in Europe, the US, and East Asia. But what about low and middle-income countries? How do we measure access? How do we assess the path of the pandemic in those countries? Well, the data that are available are relatively similar to what's reported on a daily basis in high-income countries. They come from systems that count cases and deaths that are recorded through testing, usually that are recorded as happening in health facilities, and they are compiled in various dashboards. Like here, you have the dashboard from the African CDC. Of course, now in low and middle income countries, the issues with those kind of daily data from surveillance systems are compounded. In Africa, the level of testing is roughly 2 tests per thousand people since the start of the pandemic. In Ghana, approximately 14 tests. In Rwanda, 30 tests. In South Asia, 9 tests. In Bangladesh, 2.7 tests. In Myanmar. By comparison, in the US, there have already been 246 tests per 1,000 people. So given the fact that countries test much less in African and South Asian countries, well, there will be fewer deaths that are recorded by these COVID surveillance systems. There are also a large number of deaths that occur at home or outside of hospital facilities in those countries, and hence they are difficult to count and to be included in those systems. Now, the difference between low and middle income countries and high income countries in terms of available data really stems from the extent of death registration and the extent of availability of data to measure excess mortality. In most low and middle income countries, few deaths are registered. The coverage is usually much less than what's needed to produce mortality estimates, and as a result, those data are rarely used by demographers to produce mortality estimates. As a result of the state of the data, if you would like, improving the coverage of death registration has become one of the indicators used to track progress towards the Sustainable Development Goals. But that was, of course, adopted in 2015, and progress has been slow toward that indicator of success, even before the pandemic started unfolding. One example, for example, that I'll talk about more in the rest of the talk is Malawi. We recently did a survey to assess the coverage of death registration in Malawi. And so in Malawi, country in East Africa, there have been major reforms of civil registration in the past 10 years, but among recent deaths, so in deaths of the past 3 years, only 1 in 8 deaths were registered in the country. There were gender differences. Deaths of men were more registered than deaths of women. And there were particularly stark differences in registration due to the cause of death. And death from external causes, from accidents, homicides, suicides were much more likely to be registered than deaths from other causes. So this is a typical example of a registration system that's incomplete and largely biased in the events it records. So how do we usually measure mortality in low and middle income countries? Well, the primary sources of data on mortality in those countries are surveys and censuses. So these are data collection exercises that are periodical. every 3 to 5 years for survey, every 10 years in good cases for censuses. And they usually collect data by asking respondents to report deaths among their relatives. So they ask respondents to list their parents, list their children, list their siblings, and one by one they ask whether these people are still alive, and if not, how, when, and at what age, when, and how they might have died. So these data are retrospective data, so they cover periods prior to the survey, and they constitute the main input for local and global mortality estimates. So the global burden of disease study, the world population prospects, for example, are all based on these periodical data collection exercises. Now, in the context of the pandemic, there's a major problem here, is the fact that these data collection activities are all in-person data collection activities, and for safety precautions, they've all been put on hold indefinitely. So that's the case, for example, for major survey programs like DHS and MIX. That's also the case for many censuses in countries. So for example, Ghana postponed its census by almost a year. Census operations are delayed in Côte d'Ivoire, Indonesia. There's a long list there, which means basically that at a time when we really need data on mortality, our primary source of data on that event is collapsing, is not available. So how then do we track excess mortality in low and middle income countries resulting from the COVID-19 pandemic? There are several major data issues face us. One, the first one is going to have very limited pre-COVID data on normal or baseline mortality. So reference data against which we can measure the extent of excess mortality. That might be because the most recent survey happened 3 or 5 years ago, or because there hasn't been a survey in a country about a particular age group, and so on and so forth. There are limited data on deaths that are occurring during the COVID pandemic. Again, this stems largely from the deaths in which there has been a COVID test and that have occurred in health facilities, not on the deaths that occurred in the community without tests, for example. And a lesser problem is that there are limited data on mobility and changes in population composition. So the population at risk of dying from COVID-19 or other causes of death that may be enhanced by the pandemic. So faced with those problems, the World Health Organization has recently given some recommendations about how to try and track excess mortality during the course of the pandemic in low and middle income countries. And their recommendations boil down to trying to set up or scale up data collection systems that generate counts of deaths per week. So by this, they include try to strengthen those civil registration systems that may be too limited, try to collect and transmit more data from health facilities, try to work with cemeteries and morgues, for example, that have direct involvement in the management of deaths, try to send health workers or other informants in communities to count death and report this information. And in doing so, they encourage countries to either try to use the first week when this data become available as a baseline against which they will monitor trends in mortality, or to use model estimates from the Global Burden of Disease study or World Population Prospects as baselines, so estimates that pertain to 2019 or 2000 or an earlier date. Now, there are many issues with those recommendations. The first one is that such systems are hard to establish even in normal times. And we've been trying to increase death registration for years without much success. It's a little bit difficult to imagine that this will take off now in such troubled times. Same thing, registration and burial behaviors might also change during the course of a pandemic. For example, due to lockdowns that prevent mobility, due to cemeteries, for example, becoming having less and less space, and so on and so forth. And also establishing these systems might put interviewers and interviewees or data collectors at risk of acquiring or transmitting the coronavirus because they require contact with families where the virus might be circulating and have experienced recent deaths. And finally, the model estimates that the WHO recommends as baseline are highly uncertain, and they would be measured in a different way than the data that would be collected during the pandemic. So there might be inconsistencies here that might generate spurious trends in mortality and spurious measurements of the excess mortality generated by the pandemic. So now, how do mobile phone survey potentially play a role here? And why are we investigating this avenue for collecting mortality data during the course of the pandemic? Well, the main reason is that they are safer. They're a much safer data collection alternative than in-person surveys or all the other data collection systems that have been recommended by the WHO. In mobile phone surveys, there's no need for contact between the respondent and the interviewer during which a virus can be transmitted. There's even possibilities now that interviewers can work from home, so they don't even need to work can work and be trained from home, so they don't even need to work in a call center where transmission of the virus might be happening. So it's a data alternative. That has been done before. For example, during the Ebola epidemic in Monrovia, in Liberia, there's an example of such a survey to try and measure excess mortality. And since the beginning of the COVID-19 pandemic, there's been a proliferation of mobile phone surveys in low-income countries in Africa and South Asia to cover a very broad variety of themes, from economic activity to family planning, gender, other health issues, vaccination, and so on and so forth. But no survey, or very few surveys at least, include data on mortality. And the reasons invoked for that are that data on mortality might be time demanding to collect, and that it might also be too sensitive to collect over the phone because we're asking questions about deaths of relatives. Another reason for investigating the use of mobile phone surveys for collecting mortality data is the well-known rapid increase in access to mobile phones in low and middle-income countries. So here, I simply plotted trends in the proportion of households with a mobile phone in DHS surveys that have been conducted since 2000 and 2004. And you see that in most countries, there's a clear trend towards very broad access, including almost universal access in countries like Burkina Faso or Ghana. And there are very few countries that kind of lag behind this trend. One example that I highlighted here might be Madagascar, for example. But through this mode of interview, we might be able to reach a fairly large number of population members and get data on large samples of deaths and recent events. Now, what are some of the issues that emerge in trying to conduct mobile surveys about mortality? Well, some of these issues are shared with other mobile surveys, in particular issues that pertain with sampling frame and selectivity, and not everybody has access to the phone, as you've seen from the previous slide. Some issues are shared with in-person mortality survey, issues that pertain with statistical power. Deaths are rare events statistically, and we need generally large sample to detect trends. And there's also survivor bias in those mortality surveys, because only people who have survived all the way to the survey are able to answer questions and provide data on their relatives. There are also issues that are specific to mortality measurement via mobile phone, again, the sensitivity of the topic, the time it takes to collect data, and whether it's reported accurately in an interview context that's usually rushed. Mobile phone surveys usually take less time to conduct than in-person interview, have less time available to conduct interviews than in-person interviews. So in the rest of this presentation, I will focus specifically on these three issues related to the mortality measurement via mobile phone. And I'll talk at more length about data that we are collecting in Malawi since the beginning of the pandemic. So this is all part of a study that was initiated well before the COVID-19 pandemic. It's part of a multi-country validation study of survey data on mortality supported by NICHD. And it's based in health and demographic surveillance system in several countries in Africa and South Asia that we use as reference data. In Malawi, we work in a place called the Karonga Health and Demographic Surveillance Systems in the north of the country. So if you see here on the map of Africa, Malawi is in the southeastern corner there. And Karonga is a district in Malawi that's at the northernmost part of the country, near the lake, near Lake Malawi. The health and demographic surveillance system there monitors a population of approximately 45,000 individuals. And among that population, it records all the vital events that occur to population member: death, birth, migration, marriages, and other so forth. Visits. So every few months, an interviewer traditionally visits a household and updates the household member by recording birth and deaths and migration. Because I couldn't resist and because we're all severely constrained in terms of travel, I wanted to show you pictures of the site. It's remarkably beautiful. That's the view not too far from the from the headquarters of the site. So as I said, it's against the shore of Lake Malawi, and one of the main activities is fishing. It's also an area where there's a lot of agriculture that's going on, particularly growing rice, but also other productions like maize, cassava, plantains. And it's one road it's one district that's crossed by one of the main roads in Malawi that connects Malawi to the main harbor of Dar es Salaam in Tanzania. And so there are a lot of trucks that travel through the districts to bring fuel and other supplies to the large cities of the country. In terms of our study design, the overall parent project was focused on a large validation study with more than 2,500 respondents in Karonga health and demographic surveillance systems. But in this presentation, I will focus on two sub-studies that are more immediately relevant to our tracking of excess mortality in the context of the COVID-19 pandemic. One is a simple trial of mortality data collection by mobile phone. And the other one is a panel study of COVID-related behaviors that we've been conducted since April, so since the first cases appeared in Malawi. So trying to collect mortality data by mobile phone. Our initial goal in setting up this trial was to see if we could enhance existing survey data on sibling survival by calling siblings and recruiting them into our study, and then that extended into becoming an assessment of the reliability of collecting mortality data by mobile phone. So what we did is we sampled 164 families from the HDSS. We focused on families in which there were at least 2 known siblings to the HDSS, so that we could potentially link them to those data. And within these families, we selected one index respondent at random for an in-person interview. So we did that in February and March of last year. And we asked that index respondent to notify their siblings, the siblings that they had listed during the course of the interview and during the course of data collection on sibling survival, and to notify these siblings about the existence of the study and to provide them with a phone number where we could reach them. And then we went on to try and contact these referred siblings and interview them by phone. We employed 8 interviewers that had DHS experience, so the typical skills of an interviewer, and we asked them to conduct both the in-person and mobile interviews. And these are the outcomes of the in-person interviews. We managed to enroll 124 index participants. And these index participants reported 750 maternal siblings in total, on average 6 per person, 6 per index respondent. And among those, about 1 in 5 that already died prior to the interview. 6% were too young to be eligible for the phone interview, which we set at 18 years of age. And 7.6% of them had migrated out of the country. So they were also ineligible because they were in South Africa or Tanzania, for example. So in total, there were 481 siblings who were eligible for the mobile phone studies and that we attempted to notify and contact. And among those, we were able to reach approximately 332 of those siblings, so and interview them, and they had the particularity of being dispersed throughout the country. 3 out of 4 of them were within Karonga district, including within the HDSS, but we also had neighboring districts and in large Malawian cities. So those small areas of darker blue that you see in the central region and in the southern region of the country, these are actually the largest cities in Malawi. So in terms of result then about that trial of mobile data collection. So how sensitive is it to collect mortality data by phone? So first of all, we don't do this without protections and resources for respondents. We give them multiple reminders that they have the possibility to refuse to answer any questions that they're not comfortable in answering. And we place one of those reminders prior to the start of the mortality questionnaire. We also have available referrals for psychosocial services at local hospitals and organizations in case they need them because of emotional distress, for example. And we conduct various surveillance. So the HDSS is routinely in contact with all population members, and they inquire about issues and problems that may emerge over time. And also there are explicit inquiries that were made during meetings with community stakeholders. We assessed whether the topic was sensitive through measuring refusals to answer questions, measuring interruptions of interviews and the stated reason for interrupting interviews, and through supervisor follow-ups of interviews. So in a sample of 1 in 10 interviews, the supervisor called the respondent a few days after the interview to inquire about various issues that have occurred during the interview. And we also held individual and group discussions with interviewers after each week of data collection. Our main findings in that regard is that refusals were extremely limited, occurring in less than 1% of both mobile and in-person interview refusals to answer specific questions about mortality. Interruptions of interview were frequent, but they were not related to questions about mortality. Rather, they were related to business activity, domestic chores, interruptions from children, and so on and so forth. We gathered no reports of referral to psychosocial services, and we've been in touch with respondents multiple times after this initial interview. And there were also no reports of issues gathered by other HDSS teams or during stakeholder meetings. So that's an indication to us that it is feasible and not particularly sensitive in that context to collect data on mortality by mobile phone. In discussions with interviewers, there were specific instances where they had difficulty in conducting the interview and managing interviewees' reactions. These were particularly related to accidents and violent causes of death, so things like suicides or homicides if they happen. In those contexts, interviewers reported particular issues that needed time and special care to handle. But those instances, as they report, are extremely rare, and they did not indicate that they occurred with a higher frequency, for example, in mobile interviews than in in-person interviews. I put two quotes here from our interviews with interviewers that you might read at a later time that illustrate this point. Interviewers also, several interviewers indicated that mobile interview might in fact be less likely to generate adverse reactions from respondents when answering these questions due to the role of nonverbal communication during in-person interviews in prompting kind of more extensive emotional reaction to a mortality questionnaire and recalling deceased relatives. So they argued that during mobile interviews, these nonverbal cues are less present, and there's there's a more limited dynamic towards more reactive emotional states in that context. Okay, now how long does it take to collect data? Data phone, because that was one of the things including this data in other mobile phone surveys. Well, the short answer to this is that it doesn't take longer to collect than in-person surveys. Here we have the duration in seconds to collect data on maternal survival. So that's data that we use to estimate, for example, mortality at older ages in a population. And that usually takes less than a minute to collect. So that's relatively short. Data on sibling survival takes 7 or 8 minutes on average because we elicit data on fairly large families in the context of northern Malawi. But again, there weren't any differences between in-person and mobile interviews in terms of the duration required to collect this data. And now, how accurate are those data on mortality that are generated during mobile phone surveys? So I'll focus specifically on the example of maternal survival, but we also assess data on sibling survival, paternal survival, and the results that I will discuss hold for those other sets of data. So first, the thing that we want to know is whether they report the vital status of their mother accurately. Not surprisingly, there's very high concordance between what siblings reported, depending on whether they were interviewed in person or through mobile interviews. Out of 337 reports, only one was not concordant with the report gathered from the sibling during the in-person interview. And this the report stemmed from a respondent who reported another woman as his mother. So they did not list the same woman as their mother as the in-person respondent, which might be for several reasons. One might be that we called the wrong person, and I'll talk more about that in a little bit. Another one might be that there were errors in linking brothers and sisters in the HDSS dataset, or another reason might be adoption bias. Somebody who considers, for example, second wife of the father of his or her father as as their mother, and so on and so forth, or a stepmother, and so on and so forth. So all of this might explain these occurrences, but it's very rare in our instance. Second set of finding relates to completeness of age and date data, which is often a problem in those survey data, because respondents report that they don't know the age at death of their sibling or of their relative, or the current age of their relative. And surprisingly for us, we found that missing data were less likely to occur on the age of the mother, whether it's deceased or surviving mother, during in-person interviews. So that occurred 7% during mobile than during in-person interviews, sorry. So during in-person interviews, 7.4% of the maternal reports had missing age versus 1.7% in mobile interviews. And we tried to get rid of these differences, but they remained in conditional logic models with controls for interviewers and education of the respondent. And in asking our interviewers about it, they suggested that respondents in mobile interviews were usually more inclined to accept results of probing and additional efforts by the interviewer to ascertain ages than during in-person interviews. So initially the respondent says that they don't know the age, then the respondent asks, the interviewer asks additional questions about other events and proximity to some major dates that may help to pinpoint that age. And when they narrow down the potential age of that relative, in in-person interviews, respondents may be more likely to maintain that no, they really don't know how old their mother might be, whereas that's less the case in mobile interviews. So that's one possible interpretation that I'm throwing out there. Otherwise, we're not completely sure why that's the case, but that's been fairly consistent, also depending on the residence of the respondent. The reliability of data on ages and survival, there are usually a high level of correlation between in-person and mobile data. Some of that can be explained by this adoption bias. So it's all the dots you see on the scatter plot. And the dotted line here is the line of equality between age reported during in-person interview and during mobile interview. Same thing for the data on age at death, fairly strong correlation and no systematic bias overestimating or underestimating in mobile interviews. And same thing for the data on the date of death in particular. So in conclusion of our trial here, the collection of mortality data appears feasible, safe and accurate via mobile phones in low and middle income countries. We're doing additional work at the moment to try and assess the reliability of data that we collect on months of death, for example, to control for seasonality, measurement of excess mortality. That's an important dimension in a country like Malawi, where there's a lot of malaria, for example. We are doing also assessments of mortality data collected in samples obtained via random digit dialing, so without prior referral from sibling. And we're doing additional assessments of data on mortality of neonates and children, which we haven't done so far. And how much time do I have left?
I was just going to let you know that it's just about 10 minutes to the end. So
okay.
If you could wrap up in a minute or two, that would leave a time for a couple of questions.
All right. So I will just show you some results from our panel. So as part of our panel, we've contacted a third of our initial sample of 2,500 respondents, so about 800 respondents, and we've followed them up for 3 rounds during the COVID pandemic with fairly high participation and follow-up rates. And in doing so, we're able to track how they adopt various preventive behaviors. I'm not going to talk about this a lot, but I'm going to just say a few things about self-reported symptoms. And we asked at each round whether they experience a number of symptoms that have been seen in patients with COVID-19 in other settings. And one interesting thing that we've detected is a fairly large increase in the proportion of respondents reporting a cough in the previous month prior to the survey, at least among our urban respondents. And same thing for chest pains. We've seen a significant increase in those. And that's interesting because that came at a time when there were still very, very few recorded cases of COVID-19 in Malawi, so fewer than 200 in the country. So I'm mentioning this also because being able to collect this data by mobile phone, in addition to the mortality data, might help us attribute trends in mortality that we observed in the reports about siblings and parents, for example, to COVID-19 and be able to disentangle direct and indirect effects, for example. So in conclusion, very briefly, I'll be very upbeat and positive about the potential of these mobile phone surveys. And I'll just point out that we're doing additional work on sample selection biases and tools for sample size calculations. And hopefully, we are intending to field large-scale nationally representative surveys in a few countries in the coming months. And also highlight various collaborators to this work in London, in Malawi, and in Belgium. Thank you very much, and sorry I took a long time.
No.